So there are many types of arthritis, and our interest today is to discuss particularly on osteoarthritis, because most of the arthritis forms that people talk about will have very many other different kind of managements, presentations, and the like. So our interest today is on osteoarthritis. We are hoping that we can maintain this as a series so that every month we can have a different topic to talk about, depending on what has been raised, what questions have been raised here in the clinic and the like. I'm an orthopedic surgeon working for the Machakos Orthopaedic Clinic. So this is what we intend to cover. What is it? Who gets it? How do we identify that this is arthritis? What if we don't treat? What happens to it? And also, how do we treat? And some of you will have questions about surgery, and so I will make a mention of the different kinds of surgeries that are done when it comes to arthritis. So, what is arthritis? It is a very common condition, and it basically is a wear and tear of joints. It follows wearing of the cartilage at the ends of the bones, and cartilage is a lining that is there usually in a joint. So this is a normal healthy knee joint, and when it starts wearing out, you start having surfaces that look like that. These joint changes may sometimes result in pain. So we are talking about big joints, you will have pain coming up. When you're not talking about big joints, you're talking about fingers, sometimes elbows, shoulders, they may not always result in pain. And the most important thing for us to pick out today is that it is manageable, that nobody has to sit and suffer with the arthritis. It is actually manageable. People come and ask me, is this thing genetic? Where did I get it from? How does it come about? And so here are some of the things that have been found out. Arthritis is more common in people who are above 40. And so when I have a 20-year-old young girl coming and complaining of knee pain, the first thing that comes to my mind is not arthritis. It's more common in people who are older, 40 and above. We also tend to find that it is more common in females. As a general rule, most of the patients that end up coming in our clinics complaining of knee or back or hip arthritis will be females. Obesity is a big risk factor for arthritis. And because we have said it's basically a wear and tear process, as a general rule, the more somebody is heavy, the more force there'll be on the hips, on the joints, on the back. And so one who is heavier tends to suffer arthritis more likely. People who engage in heavy activities, heavy manual work, they tend to wear out their joints and their back much more. And so we tend to see it more in people who have been participating in heavy work for a long time. If one has had an injury to a joint, whether it is a sporting injury or an accident, they tend to suffer arthritis more likely. And so I have had many patients coming and saying, I had an accident this number of years ago, I injured my knee or injured my hip or injured my back, and now I'm having pain in that joint. So it's more common after an injury. And then finally, people who tend to engage more in sports, especially contact sports, tend to suffer more arthritis than others, especially in the weight-bearing joints. You're talking of ankles, you're talking of hips, and you're talking of knees. So how do we identify that this is arthritis? It is more common in the fingers, the hips, and the knees. Those are the common joints that we'll tend to find in. And some of you may have seen your grandfathers or grandmothers or somebody else elderly in the community with a joint that looks like that or a joint that looks like that. So we tend to see it more commonly there. Most people who come to hospital because of arthritis will be complaining of pain and stiffness. And especially when it comes to the back, they'll say that in the morning when they wake up, they have this stiffness, and when they walk around for a while, the pain or the stiffness goes away. When it is more severe, we tend to see swellings, and a swollen joint will look something like this. That's a swollen knee. In the knees, in the fingers, in the elbows, in the shoulders, we'll also tend to have this cracking sound. So as they're moving, they will complain that they hear the joint making a noise. Yeah, it's more common in arthritis. And then finally, we tend to see deformities. The deformities will be in the joints that are near, that are more visible. So you will not see a deformity in hip arthritis. You'll not see a deformity in shoulder arthritis, but you'll tend to see it more commonly in knee arthritis. What tests do we do? The reality is we don't have a real test for arthritis. So many of you may have been told, go and have a blood test. We're going to check whether you have arthritis. And really what people will be looking for in something like that is rheumatoid arthritis, or checking that it is not another disease. So many lab tests will be to confirm that it is not something else. The only true test that we have for arthritis is an X-ray. And the X-ray will be targeted at looking at the amount of damage that has happened to that joint. Besides that, there is no other true test for osteoarthritis. And the X-rays will look something like this. This is an example of a knee X-ray of somebody who has a normal knee. And comparatively, we have one of damaged knees. This is somebody who would come with bowed legs. I'll show a picture sometime later of how this would look like. And the things that we're usually looking out for is we are checking, so just for orientation purposes, this is a thigh bone, this is a shin bone, or what you call the tibia, and usually there are two bones in the lower part of the leg. There is a tibia and the fibula. And this is a joint. Normally, the joint will have a gap between one bone and another, and this gap is covered by what we had shown earlier as a cartilage. Now, cartilage does not show on X-ray, and so when there is no more cartilage, we see a gap. When cartilage wears out, that gap disappears, as you can see on the right side, that the gap on the inner side of the knee has disappeared. On the outer side of the knee, it's disappearing, it's almost gone. And so somebody like this will be having a lot of pain because the thigh bone, which is a femur, and the shin bone, which is a tibia, are rubbing on each other at the knee, and that's what causes the pain. And the X-ray will be able to show us this kind of deformity. It will show us how bad the arthritis is. If it's in the hip, this on the left is a picture of a normal hip. We have the left hip here, we have the right hip. The hip is composed of this thigh bone, where it comes and meets the pelvis. And when it is normal, we'll have a gap that is between the ball and the socket. That is a normal gap. This is a normal gap. When there is arthritis, that gap disappears. And so you will notice that between the ball and the socket, the gap has disappeared. And sometimes you'll have all this extra bone that is forming on the side. When you compare this left side with this right side, you see there's all this extra bone that is forming, which is not forming on that side. As I mentioned, joints that are hidden like the hip will not be able to notice deformities. So that's an X-ray of the hip. So what happens to these patients if you don't treat them? It's very variable. We have had people who have been with us for 4 or 5 years with arthritis. It is worsening. They have X-rays as bad as what we see there, but they don't have too much pain. But you also have people who have X-rays that are not as bad as what we have seen there, and they're having significant pain. So people respond differently to worsening arthritis. But for most people, as time goes by, if you do not treat, they tend to get more pain. And if they're having a disability, the disability worsens. What is a disability? The disability may be they are not able to walk, or they are not able to go to work, they're not able to sit, sleeping becomes a problem. That tends to get worse over time. If you're talking of joints that don't carry weight, things like fingers, shoulders, and elbows, what tends to get worse is stiffness. And when the joint gets stiff, actually pain goes away. And as we'll be talking about treatment, we'll mention one of the treatments being putting in stiffness in the joint. And so in fingers, in elbows, in shoulders, they tend to get stiffness. The pain goes away, but then of course the disability comes in that now they can't move the fingers, or they can't move the elbows, or they can't move the shoulders. So how do we go about treatment when you're talking about arthritis? The aim of treating arthritis is to reduce pain and to maintain one active. The reason why somebody comes to my clinic saying, I have this problem with the knee, the commonest reason is I'm not able to sleep because of pain, or I'm not able to walk because of pain, or I can't bend my knee this way, or I can't go to church, or I can't go to the market. And so when we're treating, we need to focus on handling those specific questions, or those specific concerns that somebody has raised. And so when we think that way, then we'll have different modalities of treatment. At the beginning, we'll start with treating without medication. When we say we treat without medications, we'll go through the various examples of how we'll go about treating without medication. Or we can go to the next step of treat them with medication. The next step is treatment by surgery. And I'll also make a mention of other treatments that we have heard about in our environment that are not any of the above that we've talked about. So let's start with the first one. How can we handle treating these people without medication? The reason we are here today is to start that process of, if you have somebody who has arthritis, how do we start the treatment? And the first thing is patient education. If somebody does not know what is ailing them, they do not know whether this is going to kill them or not, they do not know whether this will worsen or not, then it becomes very difficult to treat them. And so the first step in treatment is usually education. Some of you may have noticed that when you came to our clinic, you may have been given a pamphlet that said, oh, this is hip arthritis and this is how to manage it. Some of you may have gone to our website and seen articles there about hip arthritis, or how to take care of your cast, or how to deal with fractures. The aim is to transfer knowledge to the patient so that when it comes to treating them, they know what to expect next. So the day I say I need to give an injection to the knee, they already expect it. They know this is step 2, this is step 3. That makes life much easier for both the doctor and the patient. And the next step, as we said, arthritis is more common when somebody is heavier. The next step is to talk about how can we lose weight so that there is less force being transmitted to the back, there's less force being transmitted to the knees, there's less force being transmitted to the hips. And there are different modalities of weight loss. And talking to nutritionists, talking to general doctors, they'll be able to give you ideas like changing meals so that one is eating more of fruits and vegetables than carbohydrates. That has been shown to work. Changing the timing of meals so that one is not taking supper just before going to sleep, because if somebody eats just before going to sleep, all that carbohydrate that one has eaten just goes to be stored in the body, and instead having your supper or your dinner much earlier, talking of 6 or 7 p.m., so that the carbohydrates are put into some use and not just stored. Talking about exercise now, when there is pain, of course it becomes difficult to exercise, but there's some simple exercises like walking, choosing to take the stairs and not the lift, choosing to walk to the stage and not using a boda, basically remaining active. And all those are ways of weight reduction. Other things that somebody can do, I've already mentioned, is exercise and using of an assistive device. We have noticed that many of the people who come complaining of a lot of hip pain or knee pain, just the addition of a walking stick or addition of a brace makes a big difference to that knee or to that hip. Because the principle of using a walking stick is something like you currently walk on 2 legs, and so the weight of the body is transmitted onto 2 legs. If you had a walking stick or a crutch, you are now transmitting the weight of the body onto 3 legs, which are your 2 legs plus the crutch. And that helps to distribute the weight, and by distributing the weight, we distribute the pain. So the pain ends up being less. And these modalities should all be started from the beginning, whether or not this person is going to get surgery, whether or not this person is going to end up with medication. All these things should be started at the beginning. It helps to start reducing the pain. And then after this, we can talk about medications. And there are different types of medications that we tend to give, starting from the simplest, which are drugs to apply. So as a general rule, what we try to do is to avoid complications. And one of the ways to avoid complications is reduce the number of tablets or injections that somebody is getting. And so among the first medications that we tend to give are things to apply on the skin. So we'll be talking about diclofenac gel or aceclofenac gel, or any other gels that we talk about as painkillers. So a common one is the diclofenac gel, which is available all over the country in whatever form. Here is an example of Voltaren, but there are so many other forms of this topical or drugs to apply on the skin. Then second is tablets that we need to use. I'll go back one step. Okay, so I was talking about drugs, and I said the topical medications are usually first. Then after the topical medications, the next step that we go to is using tablets. And the commonest drugs that we use as tablets are what we call the anti-inflammatory tablets. And we'll be talking about the diclofenac tablets, the brufen, the aceclofenac, and that is a common direction that we tend to go. Some people may prescribe paracetamol, but what has been seen among many of our patients and from many trials is that paracetamol is good, but unfortunately it does not seem to make a big difference to people with arthritis. Many of them will complain that it does not help them much. And so many times when you've been using topical drugs, the gels, and we have used the tablets and patients are still complaining of pain, we'll go to the third option. And the third option is usually joint injections. There are two main types of joint injections that are done. The commonest one that is usually done is the steroid injections. And anybody who has been to a clinic and either they were given an injection or they have seen their relative given an injection, it will have looked something milky. And that milky substance is usually a steroid injection. Let's forget the long names that are there. And it's the commonest because one, it tends to be cheap, and two, it tends to give almost instant relief. There are patients that we have given these injections and they have gone for a year plus without complaining of pain. But commonly, the injections that we give may need to be repeated after about 3 to 6 months. For most patients, it gives them relief for about 3 months. There's a second type of injection that has a long name. It's called hyaluronic acid. And if one has been given that injection, they may have noticed that it was not milky, it was watery. The hyaluronic acid injections, the trouble has been so far that the cost has been prohibitive. One injection tends to cost somewhere between 15 and 20,000. And it has to be given repeatedly over a period of about 3 to 6 months for us to see effect. So we are talking of 60 or so thousand shillings of injections before somebody can see the effect. And even after that, it has only been seen to be beneficial when somebody has early arthritis. And so people who have arthritis as bad as the X-rays that I've shown there do not benefit from it. So you'll notice that it is not many clinics, or it's not many orthopedic surgeons that will tend to give that injection, and that most of them will tend to give joint injections. As I had mentioned earlier, these modalities of treatment, whether it is the tablets or it is the gel or it is the injections, they need to be given together with what we said first, the treatment without medication, the patient education, the weight loss, physiotherapy and exercises, and using of assistive devices, whether it is walking sticks, whether it is some form of a brace, yeah, they need to be given together. Then we tend to see more effect. Finally, some patients end up needing surgery. If we have been at this, using the medications, using the injections and all that, and the patient is not getting better, and the X-ray is showing that it is getting worse, then we consider surgery for the purpose of, once again, taking away the pain and improving the ability to use a limb or the ability to use a joint. And for all surgeries, preparation is the most important. We need the patient to be in a fit psychological state, and so we need to educate them to know these are the surgical options, this is the best option for you, and it is the best option for you because of A, B, C, D, and as we go through the surgeries, we'll mention why one is better than the other, or why one is worse than the other. They need to be in a fit physical state, and so a lot of these patients will have had to go for physiotherapy before surgery to ensure that a joint that is not moving as well starts moving better, to ensure that they have the ability to walk, because many times doing surgery on a patient who has been bedridden does not change much. All we just end up with is a nice looking X-ray, but the patient is bedridden before surgery and is bedridden after surgery. So it really does not make a big difference. And then finally, they also need to have a fit medical state. And so many of the patients who end up going for surgery for arthritis will have had to see a different doctor, whether an anesthesiologist for the purpose of preparing them for surgery or a physician for the purpose of stabilizing their other medical conditions. They will need to have seen a different doctor to make sure that they don't have another condition that could either complicate surgery or prohibit surgery. And we will not, many of you may have noticed that any patient who comes to us after the age of 50 and needs surgery, we'll be talking about these medical, what we call medical checkups being done before surgery. So after all these have been done, the patient has been explained to, they have understood why one surgery and not the other. We have confirmed that the patient is in a fit physical state and medically they are also stable. Then we can now talk about the different surgeries that can be done. And one of the first ones is a realignment procedure. So for some patients, the condition, the arthritis is not so severe, and all we just need to do is to straighten out things like the bowing of the knees. We have noticed that if patients come early with the bowing of the knees because of arthritis, if we correct them, then we are able to change how forces are being transmitted in the knee and thereby reduce pain. If you reduce the pain, then we're able to delay a bigger surgery by about another 5 to 10 years. And so somebody coming to me at the age of 45, 50, and they're having mild arthritis, but it's beginning to cause them significant disability, this is a procedure that can help take away the pain and delay any bigger procedure by another 5 to 10 years, so that we end up having to do, if there's a need for a bigger procedure, having to do it somewhere near the 60s or in the 60s. So this is mainly for patients who do not have any severe disease. We talked about stiffness setting in. There are times when the arthritis can only be sorted out by making the joint stiff. It is more common in fingers and toes, as you can see on the X-ray on the left side, and in other joints that may not benefit so much by talking about replacement, for example, the ankle. And so on the X-ray that we're having on the left, this is somebody who had pain on the big toe because of damage to one of the joints. And so what one of the surgeons has done here is to stop movement in that joint. By stopping movement, it takes away the pain. When it takes away the pain, the patient is good. This is also something that we have had to do to quite a number of patients where we stop movement in the ankle joint. This X-ray that we are seeing on the right side, this is a shin bone, or also called the tibia, and this is a foot. And so this is a joint around the ankle. And as I mentioned, among the causes of arthritis is when there has been an injury to a joint. So this patient must have got an injury to this ankle joint, which is very common with ankle fractures. And if they are not treated well, ankle fractures, they tend to result in arthritis. And when they get arthritis, this is usually the solution. We stop movement in that ankle joint, and stopping that movement takes away the pain. So option number 2, in terms of surgeries, besides realignment, is to do joint fusions. We stop movement in that joint, and by stopping movement in that joint, the pain goes away. They remain with some disability because they cannot bend or move that joint, but the significant thing that has brought them to hospital, which is a pain, is gone. And then finally, the common one that you'll hear many orthopedic surgeons talking about is joint replacements. And the principle behind the joint replacements is because there is a wear and tear process between the two surfaces of a joint. If you take away those surfaces that are natural, which is bone and cartilage, and replace them with an artificial surface, which is metal and plastic, then there will be no pain, because when metal moves against plastic, there is no pain. The body does not sense metal or plastic. And so the common replacements that are usually done within this country, Kenya, is a hip replacement and a knee replacement. And as I mentioned, the principle is you have a metallic head or a plastic head, which is rubbing against a metal head, which is rubbing against plastic, and that results in no pain. If it is in the knee, we have a metal piece, we have another metal piece, and in between the two metal pieces, we'll put a plastic piece. And so movement that happens between those two does not cause pain. The advantage of joint replacements, and similarly, this is a shoulder replacement where we're ending up with a metal on one end and a plastic on the other end. The advantage of joint replacements is that they allow somebody to continue moving the joint, and so they will be able to walk as if they have never had a surgery. Unless you see the scar on the knee or the scar around the hip or the scar on the shoulder, you'll never know they've had any surgery. They allow realignment to be done. Remembering a picture that I had shown earlier of somebody with severe arthritis, and there was bowing of the knee joint. When we do surgery, we are able to realign the joints straight, so that at the end of it, they really basically have a normal joint. And the final advantage is that somebody is able to function better. While when we talked about fusion or fixing a joint, there is a limitation in movement. In knee replacement or hip replacement or shoulder replacement, the movement continues just about normal. The downside of joint replacements, and this is information that we have to tell all our patients, is one, they're more costly. These metals that we see being put inside here, they constitute almost 50% and sometimes more than 50% of the total costs of a surgery. And so they tend to be on the expensive side. But then the second thing that all our patients must also know is anything that has been put in the body artificially cannot last as long as what God originally gave you. And so somebody who comes to us at the age of 66 and has been walking on his knee for the last 66 years, and now the knee is paining and needs a replacement, when we put in a joint replacement, we inform them that this joint replacement could last you somewhere between 10 and 20 years. So on average, they tend to last about 10 to 20 years. There's those who will go way longer than 20 years, but unfortunately, there are some who, before even 10 years, the joints have started wearing out and need another surgery. But in as much as we call it a permanent treatment, it is not entirely permanent, because in 10 to 20 years, they may need to come and have what we call a revision surgery, whether it is to completely remove all the metals and put new ones, or just remove some of them and put new ones, but something may need to be done in another 10 to 20 years. Now, there are other forms of treatment that you will hear about. Those of you who live within Ukambani will hear about Kokimi Wamete, which I commonly hear in the clinic, basically talking about herbal preparations. There are nutritional supplements, which you may have seen in tablets that are called chondroitin or glucosamines. Some people may have recommended shoe insoles to change the alignment of the knee. Some may recommend acupuncture. And all the places where you find all these different modalities, there will be claims of how well patients have got with these forms of treatment. Unfortunately, scientific data seems to be very split about the efficacy of these modalities. And so I would recommend that before one engages in any of these, it would be good to have a discussion with your doctor to ask, if my daughter, or if my mother or my grandmother or I go for these alternative treatments, what is the expected outcome? Are there any potential dangers? It would be good to have a discussion with your doctor on these ones before engaging in them. That's what I'll say about that for now. So, this is a message that I need you to go home with. That osteoarthritis is manageable. Nobody should tell you that now that you have arthritis, you're going to die from this. No, it is manageable. Secondly, the commonest problems that people have with arthritis is pain and reduced function. And so when going to the doctor, those two items must be addressed. The pain must be addressed, the inability to use the joint or the disability that has happened to that joint must also be addressed. Thirdly, treatment is aimed at restoring function and easing the pain. And then finally, some patients, not all of them, some patients may require surgery. Thank you. I think now we're going to go into our, shall I say, question and answer